This is She's on Call, a weekly show hosted by ENT specialist Dr. Sujana Chandrasekhar and General Surgeon Dr. Marina Kurian. They'll be joined by guest experts to discuss an array of newsworthy medical and health issues. You're invited to ask the doctors anything. The physicians and their guests' views are their own and do not represent any institution. Please contact your doctor for any personal questions. Please hit share and join us live on Facebook, Twitter, and YouTube at She's on Call, hashtag She's on Call. Please welcome our hosts.
Hello, I'm Dr. Sujana Chandrasekhar. I'm an ear, nose, and throat surgeon in Midtown Manhattan and in Wayne, New Jersey. My co-host, Dr. Marina Kurian, is a general surgeon and minimally invasive surgeon in New York. And unfortunately, she can't be with us today, so you are stuck with me. I will do my best. But today, I hardly have to do anything because we have an amazing show lined up with two wonderful guests. We have Dr. Sheryl Recinos, who is a family medicine specialist and hospitalist in Los Angeles, California. She once suffered or she once experienced homelessness and has written a book about her experiences, and will talk to us not only about medicine, but about how we help people who are homeless in the United States and elsewhere. We have Dr. I'm so sorry. We have Dr. Minerva Romero Arinas, who is an endocrine and general surgeon in New York City. And she also is a founder of Latinos in Surgery organization, which looks to increase the really very small number of Latinx people represented as physicians and surgeons in the United States. So I'm really looking forward to talking to both of them. We are live on YouTube, Facebook, and Twitter, and on Shree's LinkedIn page. We will be carried on Monday from 2 to 3 on WBAI 99.5 FM in New York and WBAI.org. And we have a podcast that you can listen to at any time. But if you'd like to join the conversation, please share and like and tag your friends and join us for this wonderful hour of medicine and life and meeting these two amazing physicians. Let's start with the news of the week, as we always do. In COVID news, over 7.6 billion doses of COVID vaccine have been administered in the world. But there is still a great deal of disparity. The graphic shows that most continents can count more than 100 doses per 100 population given. However, in Africa, the number is exceedingly low, where it's 16 doses per 100 people. And even in the continents that look like they're well represented, there is huge variability in the rates. There's 80% vaccination in Western Europe, 30% in Bulgaria and other parts of Eastern Europe, for example. Europe is currently the only region in the world with coronavirus deaths on the rise, and they're up by 5%. And the UN and the World Health Organization are quite worried about this. Austria, like many European countries, is experiencing a huge fourth wave and has instituted a total lockdown starting Monday, November 22nd, and is mandating vaccines for every person 18 and over by February 1st. So we are not out of this at all. In the United States, we see areas where there are great numbers of vaccines. People are still practicing hygienic measures like wearing a mask, washing their hands, maintaining some physical distancing where capable. We have rolled out COVID vaccines in the United States from ages 5 to 11. So now 5 and up are all eligible for vaccination. Amazingly, in just the past 10 days or so, 10% of eligible children in the United States, or 2.6 million children, have had their first dose of vaccine. And by contrast, it took 5 months to roll out the polio vaccine to 10% of children back then. In addition, the CDC just approved the booster shot for all adults in the United States. And we will be talking later with our guests about how to protect yourself and your family over the holidays. And I think part of that is going to be not only vaccinations, but also booster shots for all who are eligible, which is now all adults in the United States who got their vaccine 6 months ago or more, or who got a single shot Johnson and Johnson vaccine. But it's going to also be particularly important for people whose health condition makes them more vulnerable to severe illness if they catch COVID-19. So, I'm an ear, nose, and throat surgeon, and within that, I'm just an ear surgeon. But I talk to all my patients about COVID because I think physicians and nurses are at the front line of trying to educate our patients and their families. And a patient of mine who came for her routine ear care talked to me, and she's gotten her vaccines and her booster, and her children have gotten their vaccine, but they are hesitant to give their younger boys the COVID vaccine because they've heard a lot about myocarditis. So we have discussed this in the past on the show, but I wanted to talk about it. Myocarditis is heart inflammation, and we are seeing very high rates of myocarditis, much higher than the normal incidence after active COVID-19 disease, particularly in young boys, in teen boys, and in young men. So it is a much higher chance of getting myocarditis if your child, whether they be a small child or a young adult, gets COVID-19 versus if they get the vaccine. There are just a handful of cases reported after millions and millions of doses of vaccine. On top of this, the myocarditis that they get, if the rare occurrence of myocarditis after COVID vaccination is so self-limited, they essentially rest for a couple of days, maybe take some non-steroidal anti-inflammatory drugs like ibuprofen, and they're back up and running, back to full activity. The people who are getting myocarditis from COVID-19 are really sick. They end up in the hospital or the ICU. They end up with long-term cardiac issues. So get your child vaccinated, please. Get yourself vaccinated, please. And get the booster, please. I just wanted, before we meet our guests, to talk about one other thing. I am, in fact, an ear surgeon, and I really am interested in what happens in the deaf world and the deaf culture world. And there's a really nice article I found in the New York Times about a school called the California School for the Deaf. It's in Riverside, California. It's a public school. Almost everybody who attends is deaf or hearing impaired, and their football team is undefeated this season. The team communicates with lightning speed in American Sign Language, and they have confronted not only disparaging remarks by leaders of opposing teams, denigrating them for being hard of hearing or hearing impaired, but they've also confronted the football prowess of opposing teams, and they've rolled over every team and every opponent, and they are undefeated. So in my terrible sign language, I will say to them, go Cubs. I fingerspell very poorly, but go Cubs. We're very proud of you. And now let's get back to our guests. So we are live on Facebook, on YouTube, on Twitter, on Shree's LinkedIn. We are really excited to welcome Dr. Sheryl Recinos, who is a family medicine doctor and hospitalist in Los Angeles, California, and Dr. Minerva Romero Arinas, who is an endocrine and general surgeon here in beautiful New York City, New York. As I said, Dr. Recinos once experienced homelessness as a teen and has written about it and talks about it to different groups. And Dr. Arenas is the founding member of the Latino Surgical Society. So welcome to the show, Sheryl and Minerva. We are so excited that you're joining us today.
Thank you so much for having us.
Yes, I agree. Thank you so much.
So thank you. We have so much to talk about. We have to fit it all into this 1 hour of our show. So let's start about talking about your specialty areas. So one does family medicine, one does endocrine surgery, but as we know, there's a great deal of overlap between those two. And I happen to be an ear, nose, and throat surgeon, so there's even a great overlap in what I do. If we can talk about thyroid disease. So endocrine surgery in general is a surgical subspecialty that focuses on surgery of the endocrine glands, which include the thyroid and parathyroid glands at the base of the neck, the adrenal glands, which sit above your kidneys. That's why it's called adrenal. It's above the kidneys. Glands of the endocrine pancreas, which is, we all know about the pancreas for insulin, and some neuroendocrine glands, which are mostly in the intestinal system. So, Minerva, can you talk to us a bit about what you encompass in your surgical field?
Yes, of course. I primarily focus on thyroid surgery and parathyroid surgery, which are the more common of the diseases that I treat. I do a fair amount of adrenal, but disease of the adrenal glands is actually relatively uncommon, and so it tends to be not as high volume. But this can be a wide range of what we call benign or non-cancerous disease, and also cancers of the thyroid, the parathyroids, and the adrenal glands.
So thank you. We have people watching from all over. We have Pavi and Mona watching from Germany. We have Ellen Austin watching from New York. Thank you guys so much for watching and sharing and checking in with us. Minerva, you're right. Thyroid disease is really the most prevalent of all of these diseases that we talked about. And I'm wondering, Sheryl, if you can talk to us about thyroid issues as they affect women and men. We know that they affect about 12% of the United States population. It's much more common, 5 to 8 times more common to have thyroid issues for a woman than for a man. And thyroid disease really affects a huge number of women, 1 in 8 women. We recently did a show on breast cancer, it's 1 in 8 women. We recently did a show on prostate cancer, it's 1 in 7 or 8 men, sometimes 1 in 6 men. Somehow that's like the magic number. Can you talk to us, Sheryl, about different types of thyroid disease?
Yes, the main diseases that we talk about are hypothyroidism and hyperthyroidism. The hypo refers to having less active thyroid, and hyper is a more active thyroid. It is much more common for someone to have hypothyroidism, and a lot of the time it's more common as people get older in life, especially among women. And as you see on the screen, 1 in 8 women will develop a thyroid condition within their lifetime. Now, some of the important facts here are that you need to be treated by a physician for your thyroid condition. And this is something that can be very well treated by your family physician or internal medicine physician. Things that are very important to note would be, you don't want to go and get thyroid supplements from a non-physician, because sometimes there are some dangerous practices out there. Things that we need to look at here on our slide, we have hypothyroidism and hyperthyroidism. Among both of these, you see that women are at a higher risk, especially over age 60 for hypothyroidism. They sometimes are in people who have other conditions like type 1 diabetes, celiac condition. And then in women who have had surgery, which our fellow surgeon, Dr. Romero Arinas, can talk to us about. Once you've had a thyroid removed, you would have lifelong hypothyroidism and need to have replacement of your thyroid hormone for the rest of your life.
So the symptoms can be really crazy, right? So the thyroid disease can present with feeling fatigued or blah or depressed. If you're hypothyroid, it can present with being really jittery, anxious, nervous. If you're hyperthyroid, um, when do you think about thyroid disease, Sheryl, and when do you order lab work? And I'm so glad you mentioned this random proliferation of supplements that people just are told to take. But can you talk to us about when you do labs and what the labs mean for you?
So it varies on the setting where someone is. Since I work in the inpatient setting, when I do labs for thyroid, it's generally for someone who's very sick. And I'm trying to determine if their thyroid was the cause of their acute illness. Because there are times when someone who is sick would have an abnormal thyroid lab that isn't accurate. And so we don't check it all the time. We check it, if there's an acute need, and then they follow up in the outpatient setting to continue checking it.
And then Minerva, let's talk about if somebody feels like, so the thyroid is right under the skin, right at the base of the neck here. So sometimes the patient themselves notices that they have a lump or a swelling because the choker they used to wear sits irregularly or is broad, or they're starting to wear blouses that show the base of neck. What kind of testing is done if there's a lump or a swelling in the thyroid gland, and what does that do to help us?
That's an excellent question. The best test to start off with, and it's actually a great choice because it's not expensive, it's easily done, and it's not invasive, is to do an ultrasound. That's when a doctor or a technologist will place a specific probe and some gel on the neck. And we get really good images, as you mentioned, because the thyroid is relatively superficial. It's a great way to assess the thyroid. It helps us look for any kind of lumps or what we call nodules. It helps us even actually see parathyroid glands when we're looking for parathyroid disease. And a lot of times people will get an ultrasound done actually to check, for example, their arteries. We look at carotid arteries for risk of stroke. And a lot of times a thyroid nodule will be found incidentally. And that's another reason when we would do a formal study of the thyroid. If there is something found, I think it's important, and I always tell my patients this, the thyroid is an organ that just really likes to make nodules. I'm not sure why. If I did find that out, I would probably win a Nobel Prize or something, but we know that it does that. And so the majority of nodules are actually benign or not cancerous. And I think that's a really important point. But it is important to have the nodules assessed by a physician. And oftentimes, depending on the size, we can do what we call active surveillance, which means we reevaluate and see if there's any changes. Or if there are larger lesions, then we might recommend doing what we call a fine needle aspiration biopsy. And that means that we take a really small, thin needle and take some cells from the thyroid to see if we can detect any abnormal cells.
So I will let our audience in on a little secret that ENTs and general surgeons kind of fight over the thyroid, but luckily or unluckily, there are plenty of thyroids to go around. So we can share in managing these patients surgically while we rely on our internal medicine colleagues, our family physicians, our endocrinologists to help us medically. We have a question from Kathy Joshi, and maybe I'll address this to Sheryl. She has Hashimoto's thyroiditis, and maybe you can talk to us about what that is. And she is managed on medications and wonders if she has to take those medications lifelong.
So very likely you will be on the medication lifelong. A lot of the time, once we get you to a dose of medication that stabilizes you, that is the dose that you need to supplement your thyroid for the rest of your life. It's a great conversation for you to have with your doctor, especially if you're having side effects or a reason that makes you uncomfortable continuing taking it. But these medications are life-changing, and it's great that they found your condition and they were able to get you on treatment.
So can you just explain to us briefly what is Hashimoto's or what is thyroiditis, which itis means inflammation in medicine, in Latin?
Yes, so thyroiditis is where you have inflammation of the thyroid, and it can affect your thyroid hormone production. And in this case, Hashimoto's would be one of the autoimmune conditions, meaning your body is attacking itself and causing you to have this reaction. And so, unfortunately, you do need that supplementation.
So there's a question from Sridevi Chandrasekhar. Is there a place for empirical thyroid treatment for all of these symptoms as we age? So in our 70s, 80s, 90s, cold intolerance, constipation, neuralgic pains, are these all able to be attributed to less well-functioning thyroid glands? Sheryl?
Not necessarily. When we're looking at that constellation of symptoms, yes, it could come from the thyroid or it could come from something else. Whenever you have symptoms that are troubling you and they're lasting more than a few days and they're starting to make your life uncomfortable, that would be a great time to reach out and get an appointment with your doctor because there could be something else going on, and I don't want to say necessarily that it's always the thyroid because a lot of the time it's not the thyroid.
And then I think our last question about Hashimoto's comes from Ellen Austin, and she wants to know how dangerous Hashimoto's is. Like, I think the question is, why do you have to stay on medicines for it?
As far as how dangerous, I think the proper question here is how dangerous is it not to treat it? It's more dangerous not to treat a condition like Hashimoto's where you need the supplementation. When we're giving supplementation like levothyroxine, the thyroid hormone, that's to replace a missing or low amount of hormone in your body. And so if you need that hormone supplementation, if you need that hormone for your body to function properly, not taking it can wreak havoc on your system. And so yes, it's dangerous if it's not treated, but once you're under treatment, you're hopefully more stable.
I like that answer a lot, actually. I agree with you. We do have some statistics on thyroid cancer. So Minerva, let's talk a bit. It's thyroid cancer is 3 times, as you said, most nodules are benign. And I loved when you said the thyroid just makes nodules. You're right. I'm gonna buy a ball gown and attend your Nobel Prize ceremony when you figure out why that happened. But thyroid cancer, which is, the very small minority of thyroid nodules, is 3 times more common in women. It's actually the most common cancer diagnosed in young women, but 98% of people have over a 5-year survival. And for our audience, doctors always look at 5-year survival, meaning you're pretty much off the hook after then, although we do continue to monitor you at intervals. But thyroid cancer seems to be more deadly in men than in women. So Minerva, can you help us understand these statistics?
Certainly. There's an important point which we hate to minimize, and we hate to make patients feel like we're not taking their disease seriously. But of all the types of cancers that you could have, this tends to be one of the cancers that behaves the best. And so if you have the most common type called papillary thyroid cancer, that makes up about 80 to 85% of all thyroid cancers, that disease actually tends to have a really high survival. It tends to be very slow growing. And even when we think about stages of cancer, which we use a staging system to define, has the cancer spread beyond the primary organ, in this case being the thyroid. When we see patients who have advanced stage of thyroid cancer, of papillary specifically, those people tend to have really high 5 and 10-year survivals, as you've already mentioned. There are a couple of additional subtypes that are a little bit more aggressive, and that includes the medullary thyroid cancer and anaplastic thyroid cancer. Those are less common, and they make up the second portion of thyroid cancer seen. about 3 to 5% each. And so those are a little bit more aggressive, but there are treatments for all of these. And I would say in general, for papillary thyroid cancer, for follicular thyroid cancer, and for medullary thyroid cancer, the initial treatment actually starts with surgery, and that's considered the mainstay or the primary type of treatment. For anaplastic thyroid cancer, sometimes the treatment actually starts with chemotherapy and radiation therapy before we decide if a patient will be eligible for a surgery in those particular subtypes.
So, let's talk about surgery. So, as you said, when people need surgery, well, let me back up a little bit. Sometimes it's not clear if people need surgery, right? So how do you talk with patients to help them make that decision? And then we can talk a bit about various surgical techniques that you might want to use.
Yes, I think this conversation has actually changed a lot in the time, even from the time I was training to now coming out into my own practice. And the reason for that is that up until about 5 years ago, the general recommendation was that anyone who had a thyroid cancer, regardless of size, anything that was over 1 centimeter required complete removal of all the thyroid. In 2015, 2016, there was a change in our professional guidelines that actually suggested that perhaps removing only half of the thyroid would be what we call non-inferior and reasonable treatment than removing all of the thyroid. And so I tend to use several pieces of information to help in this shared decision-making with my patients. Certainly the size of the nodule, the imaging characteristics, meaning does it look like it's spreading beyond the thyroid? Are there certain features on the ultrasound that make me suspicious about this being a more aggressive type of cancer? Sometimes we talk about seeing calcifications or essentially calcium deposits or like little pebbles within the cancer itself. There are a few different features that we look for. And then certainly, what is the patient's quality of life? What are their comorbidities? And are we seeing additional disease? For example, we talked about spread to other organs. The first place where thyroid cancer would spread would be in lymph nodes in what we call the central neck, meaning in this area in the front of the thyroid and really right around the thyroid itself. After that, we usually see spread to the sides of the neck. And so we look for those when we're doing our assessment, and that also helps guide the patient's plan of care. Another aspect that we also think about is we said that one of the treatments for thyroid cancer is surgery. An additional treatment then after that follows is the thyroid hormone medication. And another treatment is what we call radioactive iodine. And so if we have suspicion that they will be a patient that will benefit from getting radioactive iodine, then that also tends to influence what we call the extent of surgery, or just how much of the thyroid is going to be removed.
Yeah, so I think, we ask what looks like a simple question, and the answers are so complicated, which is, I think, why here on She's on Call we try to highlight the importance of seeking really robust medical advice from physicians whom you trust. Maitri Singh writes in and asks, what does it mean? What do the Bethesda levels or Bethesda level 4 mean? Is that a precancer lesion? How does one counsel somebody who is told of a Bethesda level 4 diagnosis, I imagine on fine needle aspiration biopsy?
Right. The Bethesda classification system is actually used for what we talked about a little bit earlier, called the fine needle aspiration biopsy. And what this means is that when we take that sample, we're only seeing a very small amount of cells from the thyroid. And it's actually a similar technique to what's used for women who get pap smears. It's actually the Papa Nicolau technique to look at cells under the microscope with special stains and then make medical decisions about what we're seeing. So the Bethesda system gives us a range of diagnoses. And I always like to use analogies, and I always tell people, think of a biopsy being like eating a pizza. And if you think about all of the ingredients in the pizza, if you say you had a pizza with cheese and maybe some pepperoni and maybe some bits of sausage or some olives, every time you take a bite, you might get obviously some of the crust and some of the cheese, depending on how much cheese is in there. But you're not always going to get bits of the pepperoni or the sausage or the olives, right? And so when we take biopsies, we're seeing a sample, but it may not be representative of everything. So those ranges in the Bethesda system give us sort of how suspicious are we? What kind of cells are we seeing? Are we seeing normal thyroid cells? Are we seeing cells that look very clearly like cancer? And then the ranges of Bethesda 3, 4 tend to be somewhere in the middle. And what that means is that we're seeing cells that don't look completely normal, but they don't clearly look like thyroid cancer cells. And the range of suspicion for those lower, for the Bethesda 3-4 can be up to about 30-35% risk for malignancy. And that can vary a little bit depending on where the institution, what their individual rate of those calls are. So when I see these patients who have these biopsy results indicating that we're uncertain, a lot of times the word unspecified or uncertain significance is used in those staging systems for these particular categories. What we can do is to either repeat a biopsy, or if we have taken a sample, there are special molecular tests available, and there's a variety of brands or companies that do these tests. But what they'll essentially do is look at the DNA of the cells and also quantify what the risk is. Do they think that this is more likely a cancer or not? And those can be additional pieces of information that can help patients understand the disease and make decisions. Sometimes we're just not able to get a good sample or get a good sense of what's going on. And in those cases, we might move forward with what we call a diagnostic thyroid surgery. And that means that we'll remove a portion of the thyroid. Usually, we only remove half of the thyroid in where that specific nodule was found. And that's essentially the way to get 100% diagnosis accuracy there.
Right. And thank you. I really like that explanation. You know, hemithyroidectomy or removal of half of the thyroid is a relatively, there's no surgery without risk. There's no intervention without risk, but it's a relatively low risk procedure. We have a question from Vinay about what's the chance of recurrence. And I think what you're saying, Minerva, if I can paraphrase, is if you have a nodule that's limited to one side of the thyroid and you remove that side of the thyroid, when we're there, we always feel the other side. Like surgeons don't trust anybody, right? We certainly don't trust ourselves, even with an ultrasound. So while we're in your neck, we're going to feel the other side of your thyroid, make sure there's nothing suspicious to our educated fingers. But I think that removal of that one lobe of the thyroid gland, and we have a little graphic about what that looks like in a cartoon image, is very effective. What do you counsel patients about their risks after surgery, Minerva? And I will tell our audience that I was the lead writer on the American Academy of Otolaryngology head and neck surgery clinical practice guidelines on improving voice after thyroidectomy, because one of the things we do see is some hoarseness after thyroid surgery that is usually self-limited.
Yes, I think it's important for patients to understand what they can expect after surgery. And there are some common what we call complications or some common changes. Some of the changes that we really look at are actually not considered life-threatening, but they do have a tremendous impact on the patient's quality of life. And those voice changes tend to be very disruptive. My patients, as we've talked about, a lot of patients are young women, healthy women, mothers, and one common complaint will be, I can't yell at my kids as much as I used to before.
So the kids are happy.
The kids and the spouse or partner are definitely happy, but it can be very distressing. And so we might see changes in the voice that can include hoarseness. It can also happen that you might notice a change in the pitch. These don't happen very frequently, but when they do happen, most of the time they are self-limited, as you've already mentioned. Usually we give it a trial period of about 3 months before we decide that this might be a more permanent change in the voice. A lot of times people can have speech therapy and do some vocal cord exercises to help regain that voice quality sooner. But there are cases, for example, when we know at surgery that there is going to be an issue, particularly when we're seeing some of the more aggressive cancers where perhaps we know that we had to do a procedure to cut the nerve that controls the voice. And those are cases where we might know right off the bat that this is not going to be a temporary issue. One of the other major things that we look at is that the thyroid doesn't sit in the neck by itself. It has a lot of neighbors, and one of the most important neighbors to the thyroid are called parathyroid glands. And those glands help control the calcium levels in our body and regulate our calcium, what we call calcium homeostasis or balance. Those glands actually really hate it when we disrupt them. They share a blood supply with the thyroid, and they really hate it when we take their neighbor. So sometimes we actually will see the parathyroid glands sort of poop out and they just stop working. You really only need one normal parathyroid gland to have adequate function. So depending on the type of surgery that you have, you might experience symptoms of low calcium. This also tends to be self-limited, and most of the time will go away within a few weeks of surgery. But patients might need to have calcium pills on hand in case they experience these symptoms, which can include numbness of the fingertips, numbness around the lips, numbness in the toes. And then in more severe cases, they might actually see some muscle spasms. And so it's really important to be in good communication with your surgeon so that you don't get to muscle spasm stage, because that can be very disturbing. Other things that we look for are the risk of bleeding around the surgery, especially in the neck. We don't want to have significant bleeding that can compress the airway. This tends to be a fairly unlikely scenario. It happens in about 1 to 2% of thyroid surgery, so it's not a very likely complication, but it is an important one. And then, of course, you should expect some pain. I actually, I'm very happy to share that most patients who have thyroid or parathyroid surgery don't experience enough pain to require opioid medications. And most surgeons will ask patients to start with what we call non-opioid analgesics like Tylenol, ibuprofen, if we're a little bit more daring in that. But certainly I can say evidence-based, based on a trial I had patients participate in early in my practice. Actually, most of my patients don't end up taking those types of medications.
Thank you. We are live on Facebook, on YouTube, on Twitter, on Shree's LinkedIn. We will be carried on WBAI 99.5 FM in New York and WBAI.org Monday from 2 to 3 p.m. Eastern Time. And we have a podcast We have people checking in from all over. We have Bernard West from Dubai watching. We have Vanita Sahasranaman, who is either in Manhattan or in Florida. We have Chaitana NJ, who is in the Philadelphia area. Beth Lowe, Sandra Blake Lefkowitz, Ram Balasubramanian, who is watching from Frisco, Texas. Deirdre Gruen, happy birthday, Deirdre, who's watching from Glen Ridge, New Jersey. Thank you guys so much for watching. I think I know a lot about thyroid, and I've learned a lot just from our guests today. Let's switch the dialogue a little bit and talk with Dr. Recinos. So Sheryl, you did family practice or family medicine, and now you do hospitalist medicine. And there are lots and lots of family physicians in the country, but fewer hospitalist doctors in the country. How did you choose this path, and what do you cover in your practice?
Those are great questions. So I chose family medicine because I liked the breadth of what we can take care of. I can take care of children, women who are, maternal, having children, postpartum deliveries, and then I can take care of adults, elderly populations. And so I liked the breadth of being able to take care of so many different types of conditions. And as I went through my residency training, I saw that I had a lot of options. I didn't enjoy clinic as much as I had expected to, but I loved the inpatient setting. And so when I finished my residency program, I went immediately for a hospitalist job, and I've been doing that ever since finishing residency.
And so, we talked with Mark Shapiro, who's also a hospitalist, also in California, about what that entails. And I think as I do a lot of outpatient surgery. I occasionally admit patients to the hospital. We used to take care of our own patients in the hospital. And I have to tell you, it was fine, but it was not perfect because I don't know what Sheryl knows. Like I know what I know about the ear, or maybe the ear, nose, and throat, but Sheryl knows about your whole body. So where is the interaction for when people get admitted to the hospital, if they meet a hospitalist? What should they expect from that encounter and that care?
Yes. So when I'm taking care of patients in the hospital, either I'm the only physician taking care of them if they have something that isn't too complex and doesn't require any specialist, something simple like COPD exacerbation or CHF exacerbation most of the time.
And so COPD means?
COPD is like chronic obstructive pulmonary disease. So people usually who were former smokers and now they have compromised lungs. And so sometimes they end up, getting more sick than usual, and their regular inhalers and medications at home don't work. And so they need to come into the hospital for that. The same with CHF exacerbation. That's like a congestive heart failure exacerbation, means someone who has a heart that doesn't work very well and has a backflow of fluid into the rest of their body. And so they need medication to help get all of the extra fluid out. And so simple situations like that where, I'm taking care of a patient who needs to be hospitalized for a few days and they need that care, I would be their primary physician in the hospital. Other times we'll admit for surgeons or admit alongside surgeons and act as a consultant and make sure that, we're providing all of the other care, as you were saying, because it's really hard to manage everything. And I need all of you to be great surgeons. And I don't mind. I love taking care of the rest of it. I love helping make sure that patients are doing well before and after their procedures and making sure that they have a good, safe discharge plan where they can go home and be well. And so it's a great teamwork effort where we all work together.
And I think it's really important for patients to understand that even though Dr. Recinos is taking care of them in the hospital, when they go home, you will actually communicate with their primary care physician at home, so that in fact, that concept of a medical home where we're all centered around the patient's well-being continues. So how is that communication happening?
So it's easier when we have a system that's set up like an electronic medical record that communicates between the outpatient clinics, with the hospital. And so if we're all in the same system, it's easier for the primary doctors to follow and see what's happened and to receive messages. It's a little more complex when we're not all on the same system because it's hard to reach people all of the time.
Right. So, my patients make fun of me because really the only people still using faxes are doctors, right? So we literally do fax things to each other because there are these sort of firewalls between healthcare systems and outside physicians, and we really do need to communicate. And it's very funny sometimes, like, the electronic health record spits out like this huge document, right? Who has time to read that? And I'll literally take a highlighter and just highlight the part I need the other doctor to read and help me answer. So I think we all have our little workarounds of these systems. Minerva, you became a surgeon, and I was reflecting earlier this morning that when I chose ear, nose, and throat surgery as a specialty, right away I heard that girls don't do surgery and it's not compatible with life as a woman, and my hands were too small, but I operate in the ear, so it's kind of good that my hands are small, all sorts of crazy stuff. We didn't have a lot of role models. When I chose surgery, you're a bit younger than I am, but even with you, we're not seeing enough role models, not just for women, but for women of color in surgery. So maybe it's a double-pronged question. One is how did you become interested in becoming a surgeon, and how are you paying it forward?
Yes, I will say that unfortunately, yes, we are still not seeing the diversity and the representation in medicine, and even more so in surgical fields, to really have the be what you see, which is why people say you can't be what you can't see. I never really thought about being a surgeon. I love to tell this story because I think it really highlights the importance of our interactions with students and trainees. But I was so convinced that I wouldn't be a surgeon that I scheduled my surgical rotation towards the end of my medical school rotations. And everyone who's been through medical school knows that students just agonize over the order of the clerkship experiences. And I was pretty sure that surgery wasn't in the cards for me. And so I actually had scheduled it as the very last rotation. As it turns out, I actually wasn't sure what I was going to do. And I feel like that was really beneficial to me because I went through every clerkship just trying to maximize the experience. I'm first generation. I'm an immigrant actually to this country. I have no physicians in my family, had really limited, I think, exposure to medicine before college. And so it was really important to me to educate myself on what the different fields meant. So towards the end of my surgical clerkship, I actually was in the operating room with one of the attending surgeons. And in the middle of the case, just very casually, he asked me, "Why are you not going into surgery?" And that really was a very, I would say, life-changing question, because it really forced me to think, what is he seeing in me that I'm not seeing in myself? And why haven't, like, I had to really do a lot of soul searching. Thankfully, that really changed the trajectory. And once I decided that I was going to do it, I've never looked back. I love my career. I always tell people I can't imagine doing anything else. And that's really what we want. We want people who are going to be the best physician that they're going to be. And I tell students, I don't care if you don't want to be a surgeon, but while you're on our clerkship, we want you to learn how surgery is relevant to you in your future practice. What are you going to learn that is going to then carry over? Because as you know, you're going to be probably the one close medical person to many people. and they're going to call you. I mean, I get calls from family and friends about non-surgical things all the time, and I have to draw upon my experience, oftentimes my experience as far back as medical school, because that's the last time I did formal training in a lot of these fields, right? But they're going to look to you, and that's going to be something that comes up. So I think we're making a lot of headway in some elements of diversity, particularly when we think about women in surgery. We are getting to the numbers that would help us reach what we call critical mass, and are starting to see some of those changes. I'm a fairly active member of the Association of Women Surgeons, and we're starting to see some guidelines and position statements that are really addressing important issues. I hate to say there are issues relevant to women, but they're really issues relevant to all surgeons, such as family planning, such as medical leave. And there were some recent changes. For example, the American Board of Surgery recently issued some changes around the requirements for residents to graduate, because before it was really difficult for residents to have children during residency and have to prolong their training because of that maternity leave. And so some of these policies, we're seeing changes that are really necessary for surgical trainees. You know, unfortunately, this is something that is surgery training is carried out during some of the peak years of fertility. And we're starting to see a lot of research that that highlights what we already know as medical professionals. We know that it's not good to work these long hours, and we're seeing that surgeons are particularly higher risk, but all physicians and particularly surgeons are at high risk for complications in the pregnancy, at delivery, and a lot of times we have to be put on bed rest because we're not following the rules.
But we're really we're terrible at following the rules. When for my fourth pregnancy, I had some issues and I had to be on bed rest, and to me that meant working an 18-hour day, resting a little bit the next day, working an 18-hour day. So I'm like, that wasn't right. Thank you for your advocacy. Sheryl, you've had a really interesting path to where you are. You endured homelessness when you were a teen. You were then a high school teacher in the sciences, and now you're a physician. Can you talk to us about your journey, and can you talk to us about this sort of hidden in plain sight problem of homelessness in the United States?
Absolutely. When I was younger, I went through a series of traumatic experiences, and unfortunately, that led to not just several years of being a homeless teenager, living on and off the streets, sometimes like outside, sometimes in shelters, sometimes in less than safe environments. But I also had to deal with I had incarceration when I was 13. I was in the foster care system, and all of these different intersectional areas of my life where I shouldn't have made it to the point that I made it today. But because I had great mentors along the way, I was able to not only finish high school while I was living on the streets, but I got into college and had mentors that, pushed me to be my best self. And when I first thought about becoming a physician, that was when I was 19, but I pushed that dream aside for many years because I didn't feel like I was worthy of that dream. And I went into a career teaching high school students, and I was considering other options when, again, another mentor stepped forward and said, I think it's time for you to chase your dream. You want this more than anything, and you deserve it. And that was a stepping point for me towards, trying to get something that I had never seen before. No one in my family is a physician. And I didn't really have any good exposure to the medical field. I just had this crazy dream that I wanted to go and help people and see people in places where I had never been heard or seen. And when I got into medical school at 31, it was not only a great surprise, but a great change for my family, because I went to medical school with 3 children and my husband. And we went to a foreign medical school in the Caribbean. And so we had all of this, struggle that we had to go through, but it was so worth it. And I didn't see the value in what I had gone through until I had gotten through the process. And I was already in medical school and then residency when I started to see that my interaction with patients is so very different, because I can meet them where they are because I understand a lot more about the breadth of human experience since I've gone through so much, especially in my younger years.
You know, I tip my hat, every hat I ever owned, uh, to people who, like you both, who navigate this very complicated way of becoming a doctor, navigate our own, all of us, our own inner imposter syndrome, where we just don't feel like we're good enough or we belong there. We often, as Minerva said, don't look like all those people whose pictures are on the wall. And we certainly don't have the background of them. We the both of you alluded to people who saw something in yourselves that you didn't see yourself. And I want to say that, you know, anytime any of us in any field can see something in someone that's of such great value, it's really, I think, incumbent upon us to share that vision with that person, because it really does help people see themselves. You know, we just have a few minutes, but maybe let's just talk a bit about homelessness, because we see it and we don't want to see it. And Sheryl, can you talk to us about things that we can do in society and as physicians about people who are enduring homelessness?
Absolutely. Unfortunately, we have a rise in homelessness across much of the United States, and we have such a huge population of people, especially in places like Los Angeles and New York. When we talk about the number of people on the streets, it's almost 600,000 people in our most recent count. And when we look at things that we can do specifically, if we're looking at, ways that we can exchange or change our practices so that we can be more inclusive towards patients, we need to look at, the entire picture. If I give a patient a medication for something like diabetes, I need to think about whether or not they're able to take that medication on a daily basis. Is it something that they don't have a refrigerator for? We get a lot of patients that get admitted for DKA, which is a diabetic emergency, because their insulin doesn't work anymore since it's been exposed to the heat, since there's no refrigerator to store it in. We get patients that are admitted to the hospital for foot injuries or wounds because they don't have the ability to change out their socks or change shoes. I mean, if you're wearing your shoes all night long and you never take them off and you're wearing socks that haven't been changed in days, that creates a very unsafe condition for your skin. And unfortunately, that's something that, we often forget. We need appropriate clothing and socks for patients. And it's something that we could do at a very, local level and provide clothing at our hospital settings and at our clinic settings for patients experiencing homelessness. We need to think about ways to provide more access for bathrooms and showers, and then provide, simple things like water. Here in California, we have a state law that allows for any person, regardless of ability to pay, to go to any restaurant and ask for a cup of water, and it's free. I don't understand why that's not a law in the rest of the country. We have a lot of things we need to do. We need to provide housing. We need to provide, a way to take care of people that is better than what we've done before. And so it's time for us to start thinking about how we can do better for our patients. Because when we're talking about patients experiencing homelessness or patients experiencing other conditions, such as poverty or, institutionalized racism, we're always talking about patients who are vulnerable. And if we start thinking about the vulnerable patients first, then we're able to really expand our system and help everyone. Because what helps one patient actually helps them all.
Thank you so much. I was inspired by you, donated some money for socks in Canada. And I just heard on NPR on Friday, a person who lives in a home uses 80 gallons of water per day.
Mm-hmm.
And we have people in shelters and experiencing homelessness who can't get a cup of water to drink, can't get their 8 ounces to drink, right? So I think the disparities are enormous. I think speaking about them with people like you guys is wonderful. Unfortunately, we're coming to the end. Maybe you can each give us one very brief takeaway to leave our viewers with. And I'll start with you, Minerva.
No, there's so many things that we could summarize. I'm going to borrow from Sheryl and actually say, if you do have any issues with your thyroid, it's not always the thyroid's fault, but it is important to seek professional attention. And if it is the thyroid, I'll be glad to take it out.
Thank you. And Sheryl?
My biggest takeaway is that every single person that we meet has value. Every single person has a mom or a dad, siblings, family, and it's our duty to take care of the person in front of us. We see a lot of people on their very worst day, and that's not who they really are. It's up to us to see who they are underneath the struggle and really make a difference in their lives.
Thank you so much. What a message
Beautiful.
for this Thanksgiving week in the United States. Thank you to our guests, Dr. Sheryl Recinos, a family medicine doctor and hospitalist in Los Angeles, California, and Dr. Minerva Romero Arinas, who is an endocrine and general surgeon in New York City, New York. Thank you so much to our producers for always making the show look good. It's Thanksgiving week, and we want to specifically thank all of our guests who have appeared on She's on Call, and all of our viewers and listeners who continue to support us. We'll be back live in 3 weeks on December 12th and again on December 19th. And Marina will be back for the shows, which is very exciting for me. Have a safe and happy Thanksgiving. Get your vaccine, get your booster, get your flu shot, wear your mask, keep everyone healthy.